Thank you so much for the kind introduction. Well, I'm so happy to be here, though I am a little bit nervous. Okay, just to start off, this paper was published in 2020. So I'll start with the introduction. So with the introduction, so this paper was based on the End TB strategy, particularly the third pillar, particularly the third pillar of the End TB strategy and the fourth principles. So basically, it was relied on the intensified TB research and innovation, and the adaptation of strategy and targets at country level with the global collaboration. So in settings like India, which is a country with the largest TB burden, and alone it has an estimated of around 26%, and that was during the time they published. This 26% has up to 3.6 million of estimated missing TB cases, and so there was a limited direct evidence for potential impact of active case finding in India. So the NTB strategy had 3%, and to reduce the cost due to TB to at least 0%, as well as 90% by the year 2030. So this paper was mostly based on the third pillar, which is to reduce the TB incidence rate by 30%. So with this, they wanted to accelerate the diagnosis and treatment of treatment initiation rate for TB, and this will be done through active case finding intervention, where modeling comes in. So they say that modeling suggests that active case finding should be cost effective under a certain cost threshold over a longer period of time. So with modeling, they were modeling the impact of active case finding through symptom screening as well as bacteriologically confirming test. So first they will screen and then confirm the test, where bacteriologically confirmation of test will be done using the gene expert. A gene expert is more or less as nucleic acid amplification test, which is a machine that used to diagnose resistance of rifampicin for TB patients. So this study was based on the following research questions, of which the first one was based on smear microscopy, and it says that could smear-based active case finding be more cost effective than expert-based active case finding in settings such as India? And the second question was on the benefit of using expert and smear microscopy. So what are the benefits of using expert in comparison to smear microscopy? The benefit of using either expert or smear microscopy. So the aim of this study was to model case finding that focus on both the specificity and sensitivity of a diagnostic approach. Here, sensitivity and specificity are two matrices that are used to evaluate performance of a diagnostic test or tool. And these matrices provide information about how well a test can accurately identify individuals. So sensitivity and specificity are two different metrics, where sensitivity is simply the proportion of true positive results among all individuals who actually have a disease, in this case TB. While sensitivity, I mean, the first explanation was for sensitivity, which is the proportion of true positive result among individuals who actually have the condition, while specificity is the proportion of true negative results among all individuals who do not have the condition. So to measure sensitivity and specificity, for sensitivity, you have cases for true positive, and then you divide it by the sum of true positive as well as true negative. While for sensitivity, I'm so sorry, for sensitivity, you have the value of true positive, and then you divide it by the total sum of true positive and true negative. While specificity, you have the value of true negative, and then you divide it by the sum of true or false positive and true negative. So in this model, they made some of the assumptions in order to construct the model. So the first assumption was they assumed that 15% of the diagnoses in public sector are conducted with the expert machine, and the remainder are by smear microscopy. And they also assume that active case finding consists of initial symptom screening as well as microbiological confirmation. So they are in here. They are just trying to say that first they screen the symptom, and then after symptom screening, it's followed by a microbiological confirmation test, which actually confirm that the person indeed have TB or not TB. And then the third assumption is that they assume that all TB diagnosis, all the TB cases that are diagnosed through active case finding will be microbiologically confirmed. So there is no role for presumptive clinical diagnosis. So these assumptions were made that all TB cases diagnosed through active case finding could be microbiologically testing. And I think this was the most important one because it was used to eliminate the needs for presumptive clinical diagnosis in the active case finding processes. So, and the third one, it's that they assume that all the individuals having rifampicin resistance, they are immediately initiated on the second-line therapy, while those with unrecognized rifampicin resistance are only switched to a second-line therapy after failing the first-line treatment. And we carry on with the method for the model. So when they developed their model, firstly, they started with the uninfected individuals. And these uninfected individuals is followed by latent TB infection. And after latent TB infection, after latent TB infection, it's followed by, individuals go to asymptomatic TB, which can be smear negative, as well as asymptomatic TB, which is smear positive. I think the arrow down here, it's this arrow down here, it's wrong. It's supposed to show from latent TB to symptomatic TB. I don't know why it's coming up like this because I've been changing it now and then. I'm so sorry for that. And then individuals from asymptomatic TB smear negative, they can also transition to symptomatic smear positive TB. And also, uninfected individual can go directly to either being asymptomatic TB with a smear positive or asymptomatic TB with a smear negative. While the asymptomatic TB smear negative individuals can transition or progress to a smear TB, a symptomatic smear negative TB. And those that are asymptomatic TB with a smear positive, they can also progress to asymptomatic TB with a smear positive, or smear negative. And so is the ones with smear, I'm so sorry, I don't know what's happening, but this was supposed to be smear positive. So the one with symptomatic TB smear negative are supposed to transition to symptomatic smear positive. And both of these, after individuals have either symptomatic smear negative or symptomatic smear positive, they can sort or go to health facility to seek for care. But first they have to wait for their diagnosis. And after this, individuals, they start treatment. And during treatment, some of the individuals temporarily drop out of the care cascade. And those that drop out from the care cascade, they can regress back to seeking care and wait for their result. And I think it will be sort of like just a circle. And those that say that seek care and wait for the result can also temporarily drop out of the care cascade. So, and those on treatment, they also have two possibilities. So they can either complete their treatment and they will have a lower relapse risk, or they cannot complete their treatment, of which we call treatment interruption, where they will have a higher relapse risk. So this is where active case finding comes in. So active case finding tries to break the chain with these infectious individuals, those that either drop out of the care cascade, those with symptomatic TB with a smear negative, or those with symptomatic TB with a smear positive. And during active case finding, as I mentioned earlier, there is symptom screening. Symptom screening is followed by confirmation, bacterial confirmation testing, which in this case is gene expert. So after bacterial confirmation, individuals are started on treatment. So basically, active case finding identify individuals that are infectious through symptom screening, followed by bacteriological confirmation testing, and they are started on treatment. But however, active case finding cannot determine whether they will complete their treatment or not. So it's up to individuals. So so individuals with symptom without TB progress to through active case finding, they are screened based on their symptoms, and then they are bacteriologically confirmed after symptom screening, and finally there's a false positive treatment that can happen due to active case finding, or this can regress back to symptomatic without TB. So we carry on with the model calibration. So this model was calibrated using the annual risk of TB infection and prevalence estimate that is a representative of the urban slums of India, as well as a proportion of prevalent TB cases that are asymptomatic, and prevalent TB surveys that has been done in Chennai. And the uncertainty was estimated using a Latin hypercube test sampling. And the Latin hypercube sampling test, this is a sampling test or technique that is used to define parameter from their respective ranges. And here it was done for 10,000 samples, and it was simulated, and the model was used to simulate until the year 2018. So the parameter sets were considered acceptable if they produce model outcome that align with predefined calibration target. If the parameter they are not within the range, they were discarded. And this process helped to refine the model and improve its accuracy in predicting the TB dynamics in urban slum settings. So the model was refined in order to reflect the proportion of TB cases that exhibit symptoms and percentage of individuals with positive smear who did not seek medical care yet. So as I mentioned, with the model calibration, the model was calibrated with the prevalence survey and the annual risk of TB infection and the proportion of those that have multi-drug resistant TB. So here, there is this was taken, I think, from the main text, because there was like the main text and the supplementary material, and I think this was figure 2, which shows the result of the model calibration for the 6 calibration targets. So here, the red line indicates the data that is within the range. So with model calibration, as I explained earlier on, it was done from the prevalence survey, from the slum prevalence survey of around 100,000 populations, And this was the value, the calibration target of 432, and this was within the range. As you can see, all these values, even for the annual risk of TB infection, they were all within the range. So we carry on with the interventions. So this model was used to simulate active case. The model was used to simulate active case finding algorithms, as well as the alternative screening approach. So during the intervention, the model was used to simulate active case finding algorithm and also an alternative screening approach, where the active case finding algorithm consists of symptom screening, as I explained earlier, and a confirmatory microbiological test. And this confirmatory microbiological test consists of a moderate accuracy as well as a high accuracy. So the moderate accuracy was assumed to have performance and the cost that is consistent with smear microscopy, while for the high accuracy have performance and accuracy that is consistent with the expert. So it is assumed that the high accuracy can detect this high accuracy can detect rifampicin resistant at the same time as it's detecting TB, while for the moderate accuracy cannot detect rifampicin resistant, but it can detect presence of TB. So for the alternative screening approach, they identified prolonged cough rather than any symptom screening, with prolonged cough screening, where the prolonged cough have higher specificity and lower sensitivity than any TB. So here they assume that all individuals recognized as having rifampicin resistance were immediately initiated on a second-line therapy, while those that have unrecognized rifampicin resistance were only switched to a second-line therapy after failing the first treatment, as I explained in their initial assumptions. So the TB screening phase was designed in order to identify individuals reporting any TB suggestive symptom who would then undergo microbiological confirmation. So we carry on with the sensitivity analysis. So with the sensitivity analysis here, the sensitivity of smear microscopy was 25 to 75%, as well as the sensitivity analysis of smear microscopy was 25% for smear negative and 75% for smear positive. And the treatment success rate was between 50 to 75%. And this is as a result of adoption of new and shorter regimen of drug-resistant TB. And this is also in line with the second-line treatment, which the cost was reduced by 50%. Also, these two, the treatment success rate and the cost, this was due to newer, shorter regimen for drug-resistant TB. And for the high burden of drug-resistant TB, there was a 15% incident TB, and this was as opposed to the main text. I think in the main text, it stated to be 5%. So after the sensitivity analysis, they carry on the economic evaluation. So this analysis was tracked the cost associated with treating false positive TB diagnosis. And this was driven by the imperfect specificity of screening and diagnostic tool and the lower prevalence of TB among symptomatic individuals. So in this study, they focused on the programmatic perspective, specifically considering the cost due to TB program, while excluding broader societal cost. So the focus was on service cost related to confirmatory test and patient month of first and second line treatment, and they neglected the intervention cost required to facilitate the delivery of these services. And for example, here it's the human resources. So implementation of active case finding was expected to exponentially reduce the utilization of the passive services, and ultimately this impacted the overall incremental cost. So in this study concentrated mostly on the cost of diagnosis and treatment in the public sector, and they excluded the private sector. As shown, the sensitivity analysis were performed in order to assess the impact of their assumption with uncertainty intervals around 20 plus minus 20% for all the costs. So with the economic evaluation, the economic evaluation was done for both the smear testing as well as the expert testing, where the smear was the where these two were the confirmatory tests. To carry on with the economic evaluation, so as I mentioned, with the active case finding here, they did the symptom screening and the sputum smear screening, and these were the cost in USD, as well as the expert, which was a little bit more costlier than both of the active case finding combined. And they also show the treatment cost of both the second line treatment and the first line treatment. So for simplicity of this study, they ignored the second line regimen because it was unclear what proportion of patients will be eligible for different treatment options. I think in the supplementary material, they provided a sensitivity analysis with respect to the potential future uptake of the regimen. In order to capture uncertainty interval, the uncertainty cost, they also allowed a variation of plus minus 20% for each of the cost component. So for each of these cost component for uncertainty, they allowed a variation of around 20% plus minus 20%. So the economic evaluation was pretty long. This is for both algorithm because they had two algorithms where they had a moderate accuracy testing and a high accuracy testing. So for the moderate accuracy testing was a little bit expensive, as shown here, comparing to the high accuracy testing. So the breakdown of incremental incremental service cost was associated with the active case finding intervention, specifically at the 50% incremental cost coverage rate for the two different active case finding intervention. So as I mentioned earlier, like that they did two algorithms, moderate accuracy testing and the high accuracy testing. For the moderate accuracy testing, the major driver of incremental cost was identified to be treatment of false positive TB cases in the non-TB symptomatic population, and this represented by the orange line, as I've indicated with the dotted line. So this indicates that a significant proportion of the additional cost incurred by the moderate accuracy testing strategy is attributed to treating individuals that are incorrectly diagnosed with TB. So these are the false positive cases that contribute substantially to the overall cost of the intervention. While for B, which is the high accuracy testing, so accuracy testing was a little bit contradicting to the moderate accuracy testing because the cost of treating false positive individual is notably reduced when utilizing a diagnostic test that is similar to the expert. And this is indicated also by the orange line in this graph as orange line that I've shown with the dotted black line here. And the adoption of the high accuracy testing approach, particularly with a more precise diagnostic tool, such as the expert, This leads to a significant decrease in the expenses associated with treating false positive TB cases. So in this scenario, the false positive TB treatment cost and diagnostic cost represented by the red line, also somewhere here, emerge as a primary cost driver for high accuracy testing strategy. So with the results, so this was taken from figure 2, I think, from the main text. So with the result, with the result in figure 2, the study provided, this provides a visual representation of the impact of active case finding intervention as a function of active case finding coverage, and they focus on the reduction of cumulative TB incidence over a specified period. So here they measure, they did an impact measurement where the impact of active case finding intervention is quantified as a percentage reduction in cumulative TB incidence between the year 2020 and the year 2035. So this metric serves as an indicator for the effectiveness of active case finding programs in reducing the overall burden of TB within the population. So in this graph, each curve here represents, is generated by varying the annual screening proportion from 0, where 0 is when they have no active case finding, to 1 in the entire slum of the population. So the upper endpoint of the curve correspond to the maximum screening coverage. So here, the upper endpoint represent to the maximum active case finding coverage. So the result also shows this, which I think was...
Victor.
Yes.
Hi, Victor. Can you please wrap up in the next 5 minutes?
Oh, okay. So
Thank you.
basically, this figure shows the measurement of impact and incremental spending, which was a little bit similar to the previous figure, where the impact of active case finding intervention quantified as the percentage of cases that has been averted by active case finding. So this is also similar to the previous graphs. So where they show the prolonged curve by the prolonged curve, as well as the TB symptoms. So their result, they also did a comparison of different screening algorithm of testing strategy at a fixed budget of around 20 million USD between 2020 and 2035. So this also shows that high accuracy testing have a high screening coverage. And this is also similar to the previous graph, where they represent sensitivity analysis, which aim to identify the key model parameter influencing the relative impact of high accuracy testing in comparison to a moderate accuracy testing strategies. In conclusion, they also did a positive predictive value, where this figure shows that TB prevalence decreases over time due to active case finding interventions. So the positive predictive value of the diagnostic algorithm decreases over time. So I think basically that's what they did. So their study have underscored the importance of considering the population perspective alongside other research approach in scaling up active case finding efforts to effectively address the TB burden and to improve public health outcome in high burden countries. So basically that was it, and these are the questions for discussion. Yeah, thank you.
Thank you so much, Victor. No, TB is a very complicated disease to model, but you did well breaking everything down.